how do we take forward improvement science, not just in our own organisations, but across boundaries? Might be geographic boundaries, certainly organisational boundaries, professional boundaries, and indeed across sectoral boundaries as well. That's the theme of my 20-minute input. Some of you may have heard of Marshall Goldsmith. He writes extensively on leadership issues. In fact, the Harvard Business Review said he was the world's #1 leadership thinker, which is quite an accolade. I'm not quite sure what you do to get a job title like that. It sounds wonderful. And when he wrote about healthcare, this is what he said: leading the healthcare organisation of the future will be a much more difficult task than leading the healthcare organisation of the past. I think it's felt pretty difficult up to now anyway. Tomorrow's leaders will need to learn to thrive in a new networked world, is what he said. And he kind of rubbed that point in, for those of you who might feel it's a kind of command and control, reward and punishment environment in the NHS. He pointed out leaders who cannot adapt to the new world of healthcare management will quickly be replaced. Leaders who can adapt to the new network structure and develop new capabilities will thrive. Pretty awesome stuff. So what I'm going to do reflecting on that is address these 4 questions. Why do we need leadership for improvement across boundaries? Isn't what we've done up to now good enough? Is it any different to the kind of leadership we already have? If it is, what are the new skills and knowledge and behaviours that these new system leaders need to display? And what can we do? What can we do collectively as a system and as leaders in the system to nurture and develop these leaders of tomorrow? So, do we need this at all? Well, I think we do. Here are 5 quick, compelling reasons from my point of view. I spent an interesting 3 months as part of my AQuA role last year visiting 11 major acute hospitals in the Manchester conurbation, asking them how they were going to deliver their quick plans for the future. And without exception, they all said we can just about get through this year and most of next, looking within our own organisations. But get beyond that, get into 2013, and we're going to need some radical restructuring. Vertical and horizontal across this conurbation. Yes, to balance the books, but also to meet the demanding needs of a population that doesn't get good, effective 24/7 healthcare. So quality and financial challenges will mean we need to look beyond organisational boundaries. And then when you think about improving health, the things Maureen finished talking about there, you think about your own health, it's probably only a little bit about the NHS. It's about housing and education and leisure opportunities and jobs, and critically in my part of the world it's about the lack of jobs. If you think about the austerity challenge and the wider issues we've got across the public sector, that is absolutely a public sector challenge, and in fact the financial impact on all the bits of the public sector are much greater than they are in the NHS. Interestingly, again, in Greater Manchester, one of the community budget pilots, there's a real appetite to radically reform what public services do and to work together in a much more imaginative way. And then there's the whole issue that if we just stay in our own organisational silos, I don't think we get the best answers to some of these wicked problems. We know that disruptive innovation often comes from outside the organisation. So opening ourselves up to other thinking, creating diversity and creative tension is really important. And then finally, and I'm not sure if this is deliberate design or one of the outcomes of coalition politics, but we've ended up with an interesting NHS that's going to blend competition and collaboration, that's going to promote both greater choice for the individual and more effective integration. I think that's doable. I think it's a heck of a task, and I think we need a much more sophisticated and nuanced style of leadership than we've had in the past. In brief, this is about moving from industrial age medicine, hospitals that were designed in the early part of the 20th century as big buildings on the edge of town dealing with infectious diseases, to much more networked healthcare delivery systems, integrated delivery systems that deal with the problems of long-term conditions that people suffer with for a long time, and which put the patient at the centre, that really challenges the relationship between professionals and patients and really gets us to one that is much more of shared decision making and of the co-creation of health and well-being. So that's my quick argument as to why I think we do need leadership across boundaries. What does that start to look like? Well, as AQuA, we're in a joint programme with the King's Fund, working with 8 health economies in the northwest of England to support the development of that information age healthcare, to really challenge the way people start to work. And I know there's lots of other good examples around the NHS of this kind of approach, and it is absolutely to deliver what IHI would refer to as the triple aim, to improve quality in terms of safety, effectiveness, patient experience, whilst at the same time as improving population health and making the savings that we need to make, getting a better use of resources, increasing healthcare value as Porter would describe it. And to achieve that, I think you need what Helen Bevan would call both the anatomy and the physiology of change to be right. So there are some harder edged things in here, new financial and contractual mechanisms, certainly, effective IT infrastructure, that would help, innovative, imaginative service and workforce redesign. But quite a lot of this is about the people stuff. It's about culture, it's about a different relationship with patients, families and communities, and critically it's about the leadership that's needed to make all of that happen. So if that's the case, what kind of leaders do we need? And is that going to be any different to the leadership we've got now? Well, briefly, yes, I think it is going to be different. What's the expanded answer? Just a little bit of kind of insight, I think, here from other sectors. I didn't start life in the NHS. I had a decade in manufacturing first, and was very confused when I joined the NHS in the 90s with all the talk of internal markets about how people saw competition. It was really unusual, and somehow this idea that everybody who worked in the commercial sector were kind of like Del Boy market traders, a kind of very large scale apprentice, if you can imagine, with everybody in cutthroat competition with each other all the time. Because my sense of life in the commercial world wasn't like that at all. If we think of this as through the lens of hierarchies, markets and networks, and this is adapted from some work by Walter Powell, there are lots and lots of features of the NHS that are strongly hierarchical. If you read down that list, that the main relationship is through employment relationships, that we govern by administrative edict, it certainly feels that way sometimes, formal and bureaucratic tone, players who are dependent on each other. And my contention, having been a Foundation Trust Chief Executive before I moved on to AQuA, is that even for most Foundation Trusts, the world is still like that. Some, yes, have become much more entrepreneurial. Some, frankly, just regard Monitor as another kind of regional office, it seems to me. And I think, actually, there's an argument that says some of the new constructs in the NHS look pretty hierarchical. The other end of the spectrum, we saw a lot of debate about this as the bill went through Parliament, a debate about the power or otherwise of markets. And there certainly, I think, are some people both in the acute sector and in commissioning who would like to see the forces of the market unleashed with a very different set of mechanisms. I think a much better metaphor here is to look at the literature from many different industry sectors now around dynamic networks, value-adding partnerships, strategic alliances, where there's a really interesting blend of contractual mechanisms but with really strong relationships. And if you look at the textile industry, if you look at construction, certainly at film and media, yes, they have contracts with each other, yes, there is competition, but there is a strong sense of interdependence. There is a sense of open and mutual benefit between the players and really strong relationships. And people in those environments spend at least as much time collaborating as they do competing. That, for me, is a better model of where the NHS is moving to. Although one of the things leaders will have to cope with is, my guess is we're going to have hierarchies, markets and networks interacting all at the same time. That's going to be quite a challenge. So how does that match up with the leaders we've got of today? Well, if there's general agreement that the NHS for most of its history has operated in a pretty hierarchical way, and quite a lot of the time it still does, it would be a surprise if we hadn't developed leaders who were really good at being promoted and surviving in hierarchies. And surprise, surprise, that's what we've got. This is the Top Leaders Programme Diagnostic. Some of you in the room may have done it. I think something like 700 plus senior leaders now in the NHS have been through it. Whole series of tests, 360-degree feedback. And these leadership styles developed by the Top Leaders Programme and HAY won't delve into the definitions, but they're pretty self-explanatory, I think. Directive, visionary, affiliative, participative, pace-setting, coaching. Evidence would say really good, strong leaders would have 3 or 4 dominant styles and could move between those different styles. tends not to be the case in a lot of NHS organisations. What we have is a very strong predominance of a pace-setting style. And that can deliver some fantastic results, and in many of our organisations has. It's one of the ways in which we've delivered huge change and improvement with a lot of investment over a decade to massively improve access times in the NHS. These leaders lead by example. They have high expectations of others. They tend to act pretty punitively pretty quickly if performance isn't strong enough, and they do that by removing responsibility. Not a lot of tolerance for poor performance with this kind of style. And that last point seeks coordination with others only as it impacts on the immediate task. Does any of that feel familiar with the NHS that you know and love? It certainly does for me, having spent 20 years of my career working in it. And I think that's quite a long way from what the evidence base would say about how successful leaders work across boundaries. This is from Rosabeth Moss-Cantor's work. Successful leaders achieve results through personal influence, not hierarchical power, compete in a way that enhances rather than undercuts, display humility, organisational humility and personal humility. And much as I deeply like many of my fellow teaching hospital chief executives, it's not necessarily the first characteristic that springs to mind when you think of many of them. Be multifaceted, spotting opportunities for synergies and alliances. Now, I am not by any means, this is a bit of a caricature, I am not saying that the whole of the NHS is a long way from having some leaders with those kind of style and skills. But I am saying that we need to shift the dial considerably. There are good things on which we can build. Some very interesting work done in Calderdale and Kirklees over a 2 to 3 year period, where chief executives from 6 organisations, 4 NHS and 2 local government, came together to develop a different way of working and a different style of leadership, what they termed as leading as peers, and not only thought about how they interacted together and how they could deliver results for their communities, but how they developed a different leadership style, how they nurtured and role modelled for the staff in their organisations to work in a different way. So my contention would be we do need a different leadership style, but that we're not starting with a blank sheet of paper, and we've got some really good examples already in some parts of the NHS of leaders working creatively across boundaries. The trouble is we need a lot more of that, and we need it very quickly. So what skills, knowledge and behaviours do these effective system leaders display if we're going to move from hierarchical, predominantly pace setters to people who can work with colleagues across every aspect of the NHS and in local government, and who can engage communities in the kind of imaginative way we heard from South Central in Alaska? What do they need to be doing? One of the things that I use quite a lot in my coaching practice and in leadership courses that we run is Miles Downey's work, where he talks about leadership teams needing to be able to do all 3 of these things to answer the why, the what and the how. All 3 are important and all 3 are interdependent. And in terms of working across boundaries, answering the why question means conveying meaning and purpose for staff. If up to now it's been about building the biggest, best, strongest foundation trust you can, and I recognise the measure of how many beds have you got, it's often creeps early on in the conversation when you meet fellow chief executives. If it's about moving away from that to an organisation whose success is judged on the building of relationships with others, perhaps the radical restructuring of healthcare, so we have fewer, more highly specialised acute centres with much more effective interventions in the community setting, in long-term conditions, in chronic disease management and in prevention. If we're going to move to that, there's a need to tell a really convincing story to the thousands and thousands of staff who work in our organisations about why that's important. Some people may know that Jönköping in Sweden developed this figurative patient called Esther. I know the work we've been doing looking at integration, we looked at the work Torbay had done, where they developed Mrs. Smith. What does it mean for the individual patient? If organisations are going to work more effectively in a more integrated way, how can we create a focus for that around the story of an individual patient? But I think we need to go beyond that and to be able to say to every member of staff in the organisation, and what does it mean for me? What does it mean for me in terms of my ambitions, motivations, challenges? What does it mean in terms of how I'm going to have to do my job differently? But if we're going to be successful, it can't just be having rabble-rousing speeches and giving good inspirational talks. We actually need to put in place the right kind of system architecture. That management task, answering the what question, is also critically important. It's just that it's a different set of things than the ones that have been successful to work inside organisations. It's about governance arrangements, contractual arrangements that will enable organisations to work effectively together across boundaries and do that in a win-win way to share the gains and to share the risks. It's about developing innovative service designs and I think critically new roles for staff, workforce designs that get people working in a different way. And then thirdly, having inspired people and having put in place some of those core elements, we then need to support staff to work in a different way. There's a coaching element here, role modelling behaviours, having those multiple interactions with staff that set the tone, that set the climate, that nudge the organisation in the right direction. And we can't just do that with boards. This needs to happen at every level. It needs to be distributed leadership. So if we're going to be successful, actually the job of senior leaders is to empower everyone else in the organisation to work in this different way, whether it's by redesigning patient journeys end to end to create new systems of care across a health economy, or down at the clinical microsystem, working with integrated teams so that we get teams looking after patients with long-term conditions who aren't just a diabetes specialist, but who work hand in glove with their GP colleagues, with social care, and critically with mental health practitioners as well. How do we get leaders doing the why, the what, and the how right across the whole system? One quick example of the place I was in before doing the job I'm doing now. For 6 years I worked in Bolton, and I was initially the hospital chief executive, latterly when we got the Foundation Trust chief executive. And Bolton's got a really interesting history going right back to Lord Leverhulme, huge civic pride in that community and a very strong sense of public sector partners working together across the community, with a vision steering group that combined elected members with chief officers from all the different bits of the public sector and with private sector input. And that felt quite different to anywhere I'd worked in the past. It's partly about history. It was partly about the personalities of some of the political leaders and some of the chief officer leaders in that community. And caring for the Bolton family was a strapline that united all of those organisations with the different interests and different perspectives. What was interesting was after 20 years in the NHS, how much individual learning I needed to do to operate effectively in that different kind of community. And one of the things we did was get to know each other's organisations better. Another was to take on responsibility for a bit of the place, not just for the healthcare services, but everything for what went on in that bit of a community. And I vividly remember chairing my first neighbourhood renewal action group on a wet Tuesday night in November in a community centre on the outskirts of Bolton, with the local youth throwing bricks onto the corrugated tin roof. I realise I'm not giving you a very good impression of Bolton as a community here. There are some very nice parts to it as well. I got a very different insight into the challenges that some of my partner organisations faced and the nature of some of the needs of the local community by working in that way than I would have done sitting in my hospital reading reports on it or indeed attending the odd meeting. So finally, if we accept we do need to work across boundaries and we need a different leadership style to deliver that, how does the system develop and nurture these new leaders? What's the curriculum, if you like? And Maureen's sketched some of this out for us. I think the work that IHI have done, that the Health Foundation and others are doing around defining that body of knowledge that is improvement science is fantastically important. But sometimes the risk that improvers think we just apply scientific method to management problems and then a miracle happens and it's all fine. And life isn't like that. There are other things that these new leaders need as well. They need technical know-how about how we design systems that will work across boundaries in the ways I've talked about. I think as well as improvement science, we need to learn about large-scale change, the kind of work that Helen and others have done at the NHS Institute. We need to be teaching people not just improvement science, but systems thinking. Is that on the curriculum? Do people understand how complex adaptive systems actually operate and how to get the best out of them? And in terms of personal effectiveness, we're going to have to work really hard if we're going to help people not lose the good things in the pace setter style, because it's delivered a lot for us, but add other things into that, develop new styles, new approaches, new ways of working that suit this different environment. And I think we've made a good start. I think one of the things that the Top Leaders programme has done in the NHS is name the problem. By identifying the existing leadership style, holding a mirror up to it, there's the opportunity that people can reflect on that and help themselves to do something different. I think we also need to start to think about structuring career opportunities and structuring them for breadth, not just depth. I've been very fortunate in my career. I kind of stumbled haphazardly from one job to another, and so I got lots of experience in all the different bits of healthcare. We still have too many people who just come up the primary care route or just come up the hospital route, both in terms of clinical leaders and in terms of managers. And my worry would be that the separation still further into foundation trust providers and into commissioners might make it even more difficult to get across that divide. I think there is huge learning from elsewhere. I gave you a small smattering of some of the learning from the development of partnerships and dynamic networks in the private sector. I think there's a huge amount we can learn from the commercial world about how they make those partnerships work. And I think we also need some whole system development programs. Again, one of the things that struck me as slightly odd when I joined the NHS was the way in which people seem to regard personal development as a birthright rather than something that was there to help us deliver a better service for the customer. And we need to develop some new development programs that will work across whole systems. And the final example I'm going to leave you with, these folks are from Trafford, from the Advanced Training Programme in Trafford, which is their adaptation of the Intermountain Training Programme in healthcare improvement. And over a 3-year period, there are 138 staff in 5 cohorts from Trafford being through this programme. Because Trafford's vision, if you go back 3 or 4 years, was to set out to be an integrated delivery system. They're part of our learning community, our integration learning community, and chatting to some of the staff the other week at an event, one of the really sad things is that the current reorganisation of the NHS has made that task of delivering an integrated community much more difficult. The hospital's gone off to be merged with a big local FT. The community services under Transforming Community Services have been merged laterally with another community provider, and the Commissioner aren't sure whether they're going to get to be a CCG in their own right. The thing that's keeping them going and why they want to carry on working in this way to deliver benefit for patients and the local public is the cultural change that that development programme has brought about. By working together, learning together over that period, you've now got 138 staff drawn from all the different bits of the health community who've got a shared language of improvement and a shared set of goals, and they're pretty determined to make integration work for their community no matter what the NHS restructuring is doing to them. So to come back to my 4 questions, I think leaders across boundaries are a must-have, not a nice-to-have. I think that needs new knowledge, skills and behaviours, although I do think that there's a lot of good out there already on which we can build. I think the critical thing is having the time, headroom and continuity to do this. Some of the examples that Maureen gives that are so inspiring. You've often had leadership teams who've been in place over a 10, 15 or 20-year period. I think that's true in the NHS as well, by the way, when you look at some of our most successful organisations. We need to be able to create the space, the political space and the managerial space, to let people get on with this.